To the audience, good afternoon. My name is Jean-Yves Maillard. I got the pleasure to chair this teleclass today, and today we've got a bit of a treat for you. We've got two fantastic speakers going to discourse about current healthcare cleaning guidelines. Are they sufficient to fight antimicrobial resistance spread? And it's going to be a bit unusual teleclass, as the format will be different. As I said, my two guest speakers will be conversing about that topic. So first, let me introduce you to someone that you might be really familiar with. Is Dr. John Otter, who is the director of IAPC at Guy's and St. Thomas's in London, honorary senior lecturer in healthcare infection on AMR at Imperial College London. Is very well published. He's done so many talks as well on so many interventions that you should be very familiar with John Otter, and it's a real pleasure to have him on the teleclass. Our second guest is Dr. Curtis Donskey, hospital epidemiologist at the Cleveland VA Medical Center and a professor of medicine at Case Western Reserve University. His research focuses on understanding transmission of healthcare-associated pathogens and developing effective control measures, including strategies to address environmental contaminations. His research has been funded by the Centers for Disease Control and Prevention, the Agency for Healthcare Research and Quality, and the Department of Veteran Affairs. It's a real pleasure to have both very well-known speakers today to the class. So without any more waiting, please, Curtis and John, go ahead with those presentations.
Okay, thanks, Jean-Yves. Hello, everybody. Real pleasure to be here today talking about one of my favourite topics around the role of surface contamination in the transmission of these pathogens that cause such issues in our hospitals. But actually, I wanted to start with a question for Curtis, which is exactly as on the screen. I'd be interested to hear what you think, Curtis, whether off the bat, are current healthcare cleaning guidelines sufficient to fight AMR spread?
Well, I think in the U.S. at least, I think the answer is no. The standard guideline from the CDC was published in 2008, and it does not. It has not been updated. It's currently in the process of being updated, so we're hoping to have an updated guideline coming out in the coming year. But at the current time, we have really kind of a hodgepodge of things. So in the current hand hygiene guidelines, we have comments on disinfection of sinks, for example, and what you should do to address outbreaks related to sinks. We have in the C. diff guidelines, as we'll discuss, there's a lot of statements that are kind of wishy-washy, like giving you various things that you might consider, because the guidelines in general are looking for very hard evidence based on randomized trials. And we simply don't have that kind of quality of evidence. And so the guidance really gives us a kind of general guidance, but gives us a lot of options that we can choose from.
Okay, really interesting. So from a kind of transatlantic UK perspective, I think there's two reasons why the answer is no. One is that there's some challenges with the guidance itself, and we'll come to that as we go through the discussion today. But also, even if the guidance was perfect, there's a big step from a guideline to implementation. And I think implementing good quality hospital cleaning and disinfection is one of the hardest things we have to do for a number of different reasons. Okay, let's move on and allow me to set the scene and let you know what we're going to be covering today. So we thought it would be useful to break down our discussions into three parts. First, around general guidance, a reflection on what the guidance is, with a particular focus on the US and the UK, given where Curtis and I do our thing. Then a little bit on organism-specific guidance around C. diff and C. auris. And then there's a bit of a mixture of other issues that we wanted to bring in towards the end. So we'll see how we get on. We've got a few slides to cover, but hopefully lots of discussion to be had as well. So I wanted to set the scene with this piece of cauliflower because 25 years ago, a group of researchers in the States did a study that stuck with me, and I think about often, and I think it teaches us a lot, and it's been the foundation for a series of similar studies that have taught us even more. So what the researchers did was they theorized that if inanimate surfaces really do cause transmission of microbes that cause healthcare associated infection, then you ought to be able to artificially inoculate a surface with some kind of non-pathogenic marker and then track its spread. And that's what they did, and they chose cauliflower DNA to do that. So this was in a neonatal setting, and they inoculated a telephone receiver in one of the pods, the NICU in pod D. And you can see that by the end of the study, a huge proportion of surfaces across the unit were contaminated. I think it's really interesting to look at the time that involved here. So within 4 hours, a high proportion of sites were already contaminated in the inoculated pod. Using those same time points, there was contamination across the entire unit. Curtis, MD area, any comment on that? 0 to 100% within 4 hours?
Yeah, so we also are admirers of this study and have um, done similar studies, and no real surprise that we see this type of contamination. We inoculated portable equipment in our ICU and saw transfer all over the intensive care unit. So I think, and the timing is about what you would expect.
Okay, great. So what does all this mean? It's a far cry, you could argue, to go from a small non-pathogenic DNA marker to actual transmission, and from actual transmission to reducing infection. But we now have some really, really solid data to show that not only is surface contamination important in the transmission of these pathogens or potential pathogens, but also that if we do a better job of cleaning and disinfection in various different ways, we can actually mitigate that risk. To me, I think the most compelling piece of evidence we have is this idea of the program occupant. So this association that says that if you have a patient in a room with a pathogen that can be shed into the environment, and you can see them listed there commonly, back to noro, C. diff, others, then the incoming occupant of that same room has an increased risk of acquiring. And that kind of cements the association, really. Curtis, I'm curious, when you're talking about the importance of the environment, where do you go in the literature? What evidence do you bring to bear to show that it is really important? Because there are still a few people out there that tell me, well, it doesn't really matter because it's only surfaces and hands are the only thing that are important. It's rare now, but I do still hear that from time to time.
Yes, and I think you know some of the recent studies that we'll talk about, where people have done environmental interventions that have not shown a reduction in infection, because I think in part because there are so many different sources of transmission in addition to the environment, that it's not always easy to show an impact of environmental cleaning. I like to just start with a very simple demonstration. We say that the hands are the most important source for transfer of pathogens, and we like to just demonstrate that you can very easily acquire pathogens on your hands by touching environmental surfaces. In fact, we find that you're just as likely to acquire C. diff or MRSA on your hands when you're in a room with an MRSA or C. diff patient by touching the bed rail and the bedside table as you are when you touch the actual patient. So that I think is where I start when I try to argue that the environment is more. It's certainly very plausible as a source of transmission.
Okay, so I like that. So you're kind of aligning hands as almost just like another surface in the environment. You've got your bed rail, your toilet seat, your door handle, and your hands. They're inanimate. Well, they're not inanimate, are they? They act as if they're inanimate in the way that they spread contamination in this way. Yeah, and rarely disinfected as well, and that goes for hands and other surfaces too. Okay, so let's move on then. So first of all, I'll give a brief reflection on cleaning disinfection guidance from a UK point of view. So I think one of the challenges we have is multiple sources of information and multiple sets of guidance, all of which have some overlap and just occasionally the odd contradiction. So we have the Health and Social Care Act, so that's the legal framework that an IPC service is built around, and that says a lot about the requirement for cleaning disinfection. It doesn't include very much about how we're supposed to deliver that. Then we have the National Infection Prevention Control Manual. There's one for England, one for Scotland, and that includes a little bit more information on cleaning and disinfection. And then we have the National Standards for Cleanliness, which includes some more practical information around how cleaning and disinfection is delivered. So I think we have choice when it comes to environmental cleaning and disinfection. We have a choice around product. Do we go for a detergent with or a disinfectant or a bit of both? And in terms of the procedure, the way that that's delivered into the surface, a bucket method, mop and bucket or a cloth. Are we talking about pre-impregnated wipes or automated systems to deliver? And I think if we were to ask 100 hospitals, we'd get almost 100 different responses, maybe more, about exactly how these different product and procedural combinations are put into place. And the challenge we face is not homogeneous. So all microbes have different characteristics when it comes to their persistence in the environment and their susceptibility or otherwise to disinfection. But I think we can probably draw a very broad distinction between sort of high level resistance or susceptibility to chemical biocides and lower level. So in that sort of higher level category in particular, we've got C. diff spores, and that's a big driver for the requirement for a sporicidal disinfectant, at least some of the time in our hospitals, whereas other disinfectants that don't have sporicidal capacity may be useful for those intermediate or low, which could be bracketed together as not high in a practical sense. So looking at in just a little detail about the English manual, standard precautions does not recommend routine disinfection, so it relies on detergent cleaning most of the time. And most of our patients are on standard precautions. Patients on transmission-based precautions are with known infection risks are very much the exception and not the rule in our hospitals. And for transmission-based precautions, the manual makes a specific recommendation for chlorine-based disinfectants for daily and discharge disinfection. So I've got two major challenges around this guidance. One is the recommendation for the use of detergent for most of our hospital cleaning. And the second is around the specific recommendation for chlorine. And I'll explain why I take both of those positions. So from my point of view, there are significant limitations with a detergent-only approach. We do our best to identify and understand patients with infection risks, but we don't screen for all organisms that we're worried about all of the time. That's not feasible. C. diff is a good example. We don't do screening for asymptomatic C. diff colonization, carriage, for a number of different reasons. But that means that we have patients who have colonization with significant organisms that are shedding into the environment we don't know about. Even when we do screening, there's a gap between when the sample is taken and when it's resulted in the lab, and that can result in significant contamination of the environment. The hospital environment is difficult to clean. Detergent should be okay in theory, but the reality is different because you've got to get into all the nooks and crannies. And I think if you have a disinfectant involved, then you're increasing your chances of having a good outcome. Dry surface biofilms are a particular concern that mean that susceptibility to disinfection is reduced by these organisms that are hiding in a dry surface biofilm. There are limited studies that show that cleaning, and by that I mean detergent only, reduces significant risk. There is some evidence that detergents actually spread contamination around rather than get rid of it. Whilst there isn't a big body of literature, there is some data that water and/or water plus detergents can cause some surface damage. And we do know that moving from a detergent to a disinfectant, there is some evidence of reduced transmission. So Curtis, can I throw this one your way? What are your thoughts on if I was to say I'm just going to clean my hospital entirely with a detergent? I think in theory, a detergent in a service should be able to remove all traces of significant microbes. But tell me what you think.
Yeah, so my kind of in the U.S. impression, I think the U.S. approach is really not detergent only. We recommend disinfectants, and if you are dealing with C. diff, a sporicidal disinfectant. And I think the best argument is the evidence of spreading contamination around that. And I have a slide coming up where we nicely show if we put C. diff on a surface and wipe it with a non-sporicidal wipe, we can easily just transfer it from one surface to another. And that is what is happening in rooms if you're using a detergent only. You really have to use multiple wipes. Each surface would need a separate wipe essentially to avoid the risk for transfer from one surface to another.
Okay, nice. I look forward to that slide. And then the second issue I take with the current guidance is around the specific recommendation for chlorine as a disinfectant. Now, I don't have a problem with sodium hypochlorite. I think it's a very powerful and effective disinfectant, but it's not the only powerful and effective disinfectant with sporicidal capability. So, yeah, so many chlorine-based disinfectants are not sporicidal when they're tested correctly. They can be prone to inactivation by soiling. They have a poor environmental profile and also a poor toxicity profile for staff. We know there are some compatibility issues with some materials. And it's also true that the majority of patients who require transmission-based precautions don't require a sporicidal disinfectant. So you could use a lower grade disinfectant with less efficacy, but that has more benefits in the other categories. So just to expand that a little bit, looking at the impact of soiling. This is a study I was involved in, laboratory-based, looking at the impact of various different disinfectants in a laboratory test. And what this showed is that the chlorine-based disinfectant was effective under clean conditions, but when tested under dirty conditions, it fell down and it didn't work at all. I think it's important to think about the impact of formulation when we're making choices around disinfectants. I think it's easy to say, well, quats don't work, but actually which quat, which formulation? Because if you have a sort of cleverly formulated quat, then it can actually have a much higher level of efficacy. You're not going to get to sporicidal, but you could get to an intermediate level of activity with a quat. And we saw that impact of formulation also in the study I mentioned earlier, where one peracetic acid-based disinfectant failed under dirty conditions, whereas the other was successful. So, Curtis, over to you.
Yes, and so this is the slide I referred to. You really, I think, providing strong evidence for use of an effective disinfectant for the targeted organism. So this is a demonstration we did several years ago showing that non-sporicidal products, in this case we're using a quat as the control here, can transfer spores from contaminated to clean surfaces. And so to do this, as you can see on the bottom, is a bleach wipe. So we put a large inoculum of C. diff on a benchtop surface, and then we wiped that surface with the bleach wipe, and all of the C. diff spores were eradicated. We wiped it with a non-sporicidal quat wipe, and so the first circle there shows the initial site, and we reduced the amount of contamination there, but there's still a lot of organisms there. And each of those additional plates are sites that were clean, and we're nicely showing transfer of the C. diff spores from contaminated to clean sites. I think a strong argument in favor of using an effective product against spores if you're dealing with C. diff or against pathogens rather than just using a detergent. And then this is an overview of United States CDC guidance on cleaning and disinfection. So the guidance, the overall guidance was published in 2008, and as I mentioned, that is currently being updated. But the guidance is that we should all have standard operating procedures that are in writing, education of environmental services personnel and health and other personnel, and then some direct observation of performance should occur. And we find that this is very important. We've done some observations where we find some of our environmental services people are mixing products that they shouldn't be mixing, a quat with bleach, things like that. And you really can't pick that up unless you're directly observing performance. They recommend use of a sporicidal disinfectant if C. diff rates are high. And again, that is because we don't have a randomized trial showing that a sporicidal disinfectant reduces rates of C. diff. And so the guidelines are very conservative and just say if your rates are high, use it. You don't absolutely have to if your rates are not high. All hospitals are encouraged to develop programs to monitor terminal room cleaning. And the CDC really has some updated guidance more recently where they provide input on what type of monitoring you might do and how to implement that. So the current practices in the U.S. typically use either fluorescent markers, where you place these marks on surfaces. This is an example. We use laundry detergent, which fluoresces, make your clothes glow and makes the surfaces glow under a black light. And so you apply this before cleaning, and then you go back after, and it measures the thoroughness of cleaning. ATP loop bioluminescence as well is a measure of organic material, where it's a more expensive method of monitoring. But you're measuring organic material that may indicate surfaces have not been adequately cleaned. So a lot of hospitals in the U.S. use these methods, although not probably in a very limited way. If we're using fluorescent markers, it's on a small proportion of the actual patient rooms. So that's really a major limitation, that we're monitoring but not doing a tremendous amount of monitoring, enough to really adequately assess cleaning. And then, we focus a lot in the U.S. on terminal room cleaning after the patient is discharged, which is much easier than daily cleaning. Daily room cleaning, I think everybody in the U.S. recognizes, tends to be more suboptimal. Dr. Rotala likes to use the term trash and dash, that the EVS folks come in the morning, pull the trash, replace any paper towels, and spend a small amount of their time actually cleaning and disinfecting. 21% of the time in the morning is spent cleaning and disinfecting, with a lot more time spent taking out the trash and doing that type of thing. It should be appreciated that one of the issues with daily cleaning is that this is not easy. If you go into a patient room, especially if you're in a nursing home where they have a lot of their personal items there, but even in general patient rooms, environmental services people are reluctant to get too close to the patient to disturb any medical equipment, and there's often a lot of stuff sitting on top of surfaces. So daily cleaning is difficult, and as we'll discuss when we talk a bit more about C. diff and Candida auris, it is really indicated for those organisms. And so I'll turn it back over to you, John.
Yeah, thanks, Curtis. I mean, those images just ring true. You go around any hospital anywhere in the world, and that's what you'll see. The reality of daily cleaning is just tricky. You almost got to tidy and then clean and then disinfect, and nobody has time for that. So it's a tricky problem. Okay, let's move on to think about C. diff and C. auris as two specific challenges when it comes to cleaning and disinfection. With C. diff first. So I had a quick trawl through the guidance just in preparation, and came upon this document as the core kind of guidance around C. diff in the UK. It is being updated. We're awaiting a new version. But in terms of environmental cleaning and disinfection, this is what the guidance recommends. So again, you'll see specific reference to a chlorine-containing agent with at least 1,000 parts per million of available chlorine. A focus on commodes and bathrooms, which makes sense. Regular assessment of cleaning, particularly thorough disinfection at the time of patient discharge, and a recommendation there to consider the use of vaporized hydrogen peroxide in some circumstances. Decluttering, as we've just referenced with those pictures, routine environmental screening, not useful routinely, but possibly during outbreaks. And I think that last point is really important. It's quite wordy, but essentially it's talking about responsibility for cleaning, making sure that there are accountable people with the ability to influence the organization in order to ensure effective standards of cleaning and disinfection. Curtis, I'm interested in the US view currently on automated room systems when it comes to C. diff. Is that something that's regularly done? If you have a patient with C. diff outside of an outbreak setting, would that room get a dose of hydrogen peroxide or UV?
So hydrogen peroxide is very rarely used in the US, but UV is common. A lot of hospitals have UV devices, and they're probably underutilized for sure, because they do take a bit of extra time to move in and out of rooms. But when they are used, it tends to be in C. diff rooms and potentially in other isolation rooms. So we use it. We have UV. We use it in our C. diff rooms routinely, and then when time is allowing it, in other isolation rooms as well. So a lot of people are using those devices. The current C. diff guidelines, however, do not recommend these technologies, just again because they don't see that there is a solid enough body of evidence, and I'll come to that in a minute.
Okay, great. Let's move it on then to the US cases.
Okay, so the C. diff guidelines in the US were updated recently, so the 2022 update for strategies to prevent C. diff in acute care hospitals. And so they divide this into essential, additional practices, and things that you really shouldn't do. So the essential practices for cleaning: adequately clean and disinfect equipment and the environment of CDI patients, develop and implement protocols, dedicate non-critical patient care items or make sure that it's adequately disinfected, assess the adequacy of room cleaning, including working with environmental services, as was mentioned, for the UK. And again, we have this statement, consider use of a sporicidal agent if cleaning is deemed adequate and ongoing transmission. So again, the guidelines don't come out and say you should use a sporicidal product for every C. diff room. I would just tell you that the practice almost everywhere in the U.S. is that bleach or an alternative sporicidal product is used in C. diff rooms in the U.S. And many hospitals, for example, where I am, many of the major I think all three of the hospital systems outside of the VA where I am use peracetic acid based sporicidal products, which tend to be a bit less caustic to the environment than bleach products. So those are the essential practices. Additional practices, they say, again, if your rates are not where you want them to be, then move to using an EPA approved sporicidal disinfectant. And then, as I mentioned, they're kind of wishy-washy in terms of not specifying exactly where you should be doing this or how you should be doing this. So they say you could do this in C. diff rooms only. You could do non-CDI rooms and common spaces. You can do this with daily cleaning, or you can do it only for terminal cleaning. And they basically say use your judgment in how you decide to implement this type of disinfection. So, I'm a big proponent of daily sporicidal disinfection of high-touch surfaces in C. diff rooms, and also Candida auris. And this is kind of the data explaining why we're in favor of that. So we did this study where we went into C. diff rooms, and what we're looking at here is hand contamination. And so we would touch surfaces in the room and assess whether our hands became contaminated. And you can see at baseline, very frequent pickup of C. diff on hands. And then with no daily disinfection, you see the red bars there, all throughout the 6 days that we continue to follow, you're frequently acquiring C. diff spores on your hands when you go in and touch surfaces in those rooms. In contrast, and this was a small randomized trial, when we did daily bleach disinfection of surfaces in the room, we dramatically reduce the amount of C. diff that you acquired on your hands. So we use this evidence to try to promote our environmental services people to go in every day and do sporicidal disinfection of surfaces. And then there's also a lot of discussion in the U.S. about routine use of sporicidal disinfectants in all patient rooms. This is an area of ongoing debate now. So this was a recent study. Phil Carling and others conducted this study where 8 hospitals switched to use of a peracetic acid disinfectant in all patient rooms, moving from not using sporicides in non-CDI rooms. And it did that in conjunction with fluorescent marker monitoring. And as you can see there, the red line shows control hospitals where there was no reduction in hospital onset CDI, and the intervention hospitals where they implemented use of sporicides everywhere. They saw a significant reduction in C. diff. So this is evidence that can be used in support of using a sporicide everywhere. And as I mentioned, many hospitals in the Cleveland area do this. They use a peracetic acid-based disinfectant everywhere in their facility. And then there are some unresolved. The guidelines comment on unresolved issues, and as we mentioned, touchless technologies, hydrogen peroxide or UVC are listed as an unresolved issue. And the reason for that, again, is we do not have convincing and repeatable evidence that UV will reduce contamination. Reduce HAIs. So there are 3 randomized trials that have looked at addition of UV to standard room cleaning and disinfection. So in the first study, called the Better study, they did see a reduction, an 11% reduction in hospital-wide C. diff, and a reduction in VRE when they added UV to a quat, but there was no increase. There was no improvement when they added it to bleach cleaning. And then in 2 other recent trials, there was no reduction in VRE or C. diff or in overall HAIs when they implemented UV. So in the absence of stronger evidence, the CDC is not recommending UV as a standard. And so I'll turn it back over to you, John, for Candida zyma auris.
Okay, so step back, Curtis. So that first study, the Anderson study, cluster randomized multicenter trial, Lancet, it was pretty strong. I appreciate single study, but we don't have a study of that strength for hand hygiene.
That's correct. So I think one could make a good argument. So the Better study, the Anderson study, is the first randomized trial there with the 9 hospitals, and again they did show a reduction. The reduction was when they compared the addition of UV to quat alone. But again, they did not see a reduction in the group where they were using bleach in isolation rooms, and so that evidence is there. But again, two other recent studies have not shown a reduction. So I think we have some evidence in support, and again, a lot of hospitals in the U.S. do use these types of technologies. I think because of that evidence. Just again, the CDC, the guidance is very conservative, and so they're not coming out with a recommendation that this is something that everybody should do based on the evidence that's available.
Okay, interesting. Thanks, Curtis. So Candida zyma auris, our new friend. I've enjoyed the pleasure of managing an outbreak of this organism at the moment. So this is very live for me. I've been living and breathing this guidance developing in the UK over the past couple of months. It's a relatively new guidance published in the middle of August this year, and replaced some draft guidance that was similar but had some important differences. So C. auris is a fungal opportunistic pathogen. Generally won't cause infections in most patients in hospitals, but occasionally, especially for patients who are immunocompromised, it can cause really difficult to treat infections, and occasionally linked to increased morbidity and mortality. So it's an emerging issue, and I think that the principal concern is around antifungal resistance that comes with Candida auris, as opposed to other similar and related fungi.
Yeah.
So, as part of the UK guidance, this is the recommendations around equipment, and there's a separate set of recommendations around the environment. So it's good to see. I like the fact that there's a real focus on equipment and shared medical equipment. There's several different studies that have implicated individual items of equipment that go from patient to patient in transmission. So I think it's a good thing to shine this light on this particular aspect of transmission risk. So the guidance recommends using single-use or disposable equipment where possible. Now, clearly, that's not always possible. For some items of equipment, you just can't do that. The piece of equipment is too complicated or too expensive to make single-use a reality. But the recommendation is we can where we should. If we can't use single-use or disposable, then we should dedicate the equipment to a single room wherever possible, or a cohort. Ensuring that cleaning and disinfection of care equipment is performed in accordance with manufacturer's instructions. And I think this is a really interesting area for IPC to step into a little bit more. We often go out to the wards to do hand hygiene audits and spend a lot of time observing practice around hand hygiene. Historically, certainly in the UK, we've spent little time observing performance around equipment cleaning and disinfection. It's something we started doing in our hospitals in London in response to this outbreak, developing a kind of structured audit for measuring the performance of cleaning and disinfection of shared medical equipment. But I'd be interested to hear from the other side of the Atlantic on this point, Curtis, whether this is something your teams routinely do. Do you go and gather information about performance around cleaning and disinfection, particularly of shared medical equipment?
So we, in the U.S., some monitoring of terminal room cleaning is in place in most facilities, but very little related to portable equipment. And there are even very, very few studies where anyone has even looked at interventions to assess and monitor or improve cleaning of equipment. So this is really an area that urgently needs some attention.
Right, because if we're interested in performance around hand hygiene, we should be equally interested in performance around disinfection of shared medical equipment.
Yep.
Yeah. Okay. So, yeah, mobile equipment. Yeah. So that is something that we'll look at if we have time today, is around the ownership for cleaning and disinfection. I think there has to be clarity around roles and responsibilities for cleaning each item, who cleans what matrix, to say which member of the team cleans which item of equipment. Otherwise, you get into this loop where the nurse thinks the cleaner's doing it, the cleaner thinks the doctor's doing it, the doctor thinks the nurse is doing it, and in fact, nobody's cleaning this item of equipment. So responsibilities around cleaning and disinfection are key. And then the separate recommendations around cleaning the environment. There's a recommendation for thorough cleaning prior to disinfection, which gets a big thumbs up from me. Thinking about local policies focused on frequently touched items, which is great. Again, this repeated focus on chlorine-based disinfectants is there, although good to see an alternative effective disinfectant is there, so that's good. A recommendation to avoid quaternary ammonium compounds due to insufficient evidence of efficacy. I'm not sure about this. I've looked at the evidence. There is some evidence that an unformulated quat is ineffective against C. auris, but there is some evidence that formulated quats do have the level of effectiveness that we'd consider okay. So I'm not so sure about that one. HPV UV as supplementary nozzle replacement, that's reasonable. Reviewing whether we're doing things right, especially in outbreaks, and alignment with the national manual that we've talked about earlier is quite helpful, because otherwise we get one set of guidance saying something and another set of guidance saying a slightly different thing, and that's quite difficult to manage from an operational delivery point of view. So, Curtis, I'm interested to hear where the US is at with this.
Okay, so yes, so C. auris is an emerging problem in the U.S. as well. The current guidance is to use an agent with an EPA claim against Candida auris. So the list P, um, no touch devices are used only as an adjunct, and then do cleaning at least daily, and post discharge, and along with education of personnel. So I agree with the comment about quaternary ammoniums are not products are not consistently effective against C. auris, and so we would look and see if the particular product has made it onto the list as an active agent against C. auris approved by the FDA. Um, and the recommendation for cleaning not just once a day or at the end of an admission is based on this type of data showing rapid recontamination of surfaces after cleaning rooms of C. auris patients. So this was a study done by the CDC where pre-cleaning you see Candida C. auris, and these patients are often co-colonized with lots of other organisms. You can see all those listed there. So after cleaning, and disinfection of surfaces, the C. auris in the environment was reduced to zero. But within 4 hours, they already saw reaccumulation of pathogens on surfaces, C. auris and the other organisms. And I know John has done some work. You've done work with this as well in the past with other organisms, showing that after using HPV, you can rapidly get recontamination as well. So there's lots of evidence that we need to do more than just cleaning and disinfection when patients are discharged. And then, know your disinfectants. It's important to be aware that chlorine-based disinfectants require additional contact time for C. auris, so you need to make sure you're getting adequate contact time. So when this was a study we did looking at sodium hypochlorite or NADCC, where we found that we recommended using a product with 4,000 parts per million of available chlorine because you could get a reduction of at least 3 logs within 1 minute. But you can see that if you're using something that has 1,000 parts per million, you really need to make sure you have adequate contact time, because when you need to have at least 4 minutes to get an adequate reduction when you had 1,000 parts per million, whereas with 4,000 parts per million, even with 1 minute exposure time, you got a good reduction in C. auris. And now back to you.
Okay, so Curtis, what do you think is a realistic contact time for a wet disinfectant on a hospital surface?
Bill Rotala has done some work where he has looked at a lot of the evidence, and it thinks that we should be using a 1 minute contact time and showing at least a 3 log reduction in pathogens with 1 minute of contact time, thinking that is more reflective of real world contact time. We tend to see that, for example, horizontal surfaces tend to stay, have good contact, have better wet contact time than, for example, vertical surfaces that do tend to dry more quickly, where a shorter contact time of 1 to 2 minutes might be more realistic than a 4 minute or longer contact time. So, I don't think there's an absolute, but what I tend to like that assessment. We'd like to get a 3 log reduction in 1 minute to reflect real world use of disinfectants.
And how would you even measure surface wetness? Is there a way to do it? Is there a surface wetness monitor you can use?
So I don't think there's a real way other than you observing the surface. I know that there is. I have seen some recent studies where they've used like a wipe, where they've touched the surface to see if there was any wetness
Okay.
remain.
Yeah.
I don't think there's a good way to do that other than visually assessing the surface.
Like good old-fashioned capillary paper, that kind of thing. That might do the trick.
Yep.
Okay, good. Let's move on then and start thinking about some of the other things we wanted to throw in. I wanted to talk about the EPA, Curtis, because that is a really big difference between the UK and the US. During my time in the US, it was very clear that the EPA and the lists that you've talked about of approved hospital disinfectants, everybody used them, everybody stood by them, and it brought a great deal of simplicity to the process of selection. Unfortunately, in the UK, we just don't have that. We don't have an exact EPA equivalent. We don't have a list of hospital approved disinfectants. So it can be very hard to be certain that a disinfectant is what it says it is, or that the testing that's being presented to you, that's been done in all kinds of different test labs in this country and elsewhere, are valid and up to date. So I don't know whether you actually know what's the history of the EPA and those lists of hospital approved disinfectants.
So I do not know when that came about. I know that our infection preventionists, so our nurses, when we have norovirus or C. auris, they will go to those lists as a kind of their Bible for what products have been registered with the EPA and been shown to be effective. But in terms of the history, I actually don't know how long those lists have been out there, but I know that it seems like since I've been in practice more than 20 years ago, those lists were already in place.
Okay, would be nice to have them, but I don't think we'll be having anything similar anytime soon over in this country. Okay, so I wanted to just think more broadly around the factors influencing biocide effectiveness, and that those can be categorized into the biocide itself in terms of the type and the concentration and the formulation, the way that it's applied, and the microbe itself, and whether there's any inherent structural reduced susceptibility or acquired reduced susceptibility, or the way that the microbe is living, either in a kind of free living or in a biofilm or something like that, that actually alters its susceptibility. And recommend a nice review by Jean-Yves and colleagues that kind of pulls some of these issues together. I just wanted to pick one or two of those to talk about briefly. So I mentioned this before, but this is a nice piece of review work. So somebody in the UK pulled a whole load of hospital policies through a freedom of information request, which an organisation has to comply with, and they looked at their cleaning and disinfection policy, and they said, let's look at the policy and let's look at all the items in the policy and work out whether there's a defined method for cleaning it, whether there's a defined responsibility for cleaning it, and whether there's a defined frequency for cleaning it. And for over the half of the items they looked at, there was no defined responsibility for cleaning this item. So if nobody's responsible for doing it, the reality is it's just not going to happen. And if I can point your attention to the fairly recent work from Brett Mitchell in Australia and his team, they did a really nice study, which was a randomized trial intervention study, where they looked at implementing 3 hours of additional cleaning focused on shared mobile medical equipment in some wards and not in others, and then crossing all that over. And stepping that in rather as an intervention and looking at how that impacted healthcare associated infections. And I think remarkably, there was a significant reduction in the rate of healthcare associated infection, just based on 3 hours of doing more cleaning, disinfection, and medical equipment. One of the interesting points of this study was actually, in speaking with Brett, it was quite hard for them to find people to do this extra cleaning. Nobody really wanted to do that. It's not a job that anybody really jumps at to say, oh, I'd love to sit there in a room in a hospital and clean medical equipment all day. So I think that just illustrates the challenges we have of delivering some of these effective interventions. And I think the scale of reduction in healthcare associated infection surprised me, from around 15%, which was a little high to begin with, to less than 10%. I think it's a 30 odd percent, 38% reduction in the incidence of healthcare associated infection just by doing this cleaning and disinfection intervention. So, Curtis, what do you think? Biologically plausible to see that scale of reduction based on a bit of extra cleaning and disinfection of equipment?
So it's a very intriguing study. So I do think that there is some plausibility here. There's so much movement of equipment from patient to patient without being cleaned. So improving disinfection of equipment between use could potentially reduce HAIs. The scale of reduction here is surprising, and the 15% HAI rate at baseline, and typically if you look at the CDC data, they say that 3% of patients in the U.S. will acquire an HAI. So then the number of so there are a lot of questions about this study, but in terms of plausibility, I think it's plausible, and this really deserves to be repeated again. I'd love to see a study in the U.S. And then the other comment, I think you're very correct. It's hard for a study, you can envision getting extra staff to do this type of cleaning and disinfection, but in sustaining that type of improvement, I think could potentially be difficult. So one of the things we're looking at is use of things like UV light. We're looking at far UV light that you could put up in equipment rooms and in equipment alcoves, where equipment often is stored on the ward, in a little alcove on the ward, where the lights would be on to decontaminate equipment, but then would turn off if someone comes into the area to avoid any unnecessary UV exposure. So I think this may be an area where some sort of technologic advancement might help us to improve disinfection of equipment.
Yeah, I agree with all of that. And I think in parallel with this sort of technological solutions, rather than employing somebody whose job it is to sit there in an equipment room and clean disinfection, which, we're always going to struggle to recruit to that, making it a part of everybody's responsibility, I think, is a better approach in terms of kind of broad, effective implementation of this kind of step.
I would just add one comment. We've done some recent kind of observations of cleaning, and one of the things that we do, and I think a lot of others do as well, is for some of our portable devices, we'll attach a canister of wipes directly to the equipment, because it's hard to ask a nurse to clean a piece of equipment if they have to walk across the ward, find the wipes, take them back to the equipment. Whereas if it's directly attached to the equipment, we have to make it, if we're asking people to do it, we have to make it very easy for them to do it.
Okay, so wipes in the eye line at the point of care. I like that. It's good strategy. Okay, so my final point really today, before we hear Curtis's other points, is around the prospect of reduced susceptibility to biocides, and whether that's whether we're standing on a burning platform with all this talk of effective disinfectants. So I think just for the purposes of this brief discussion, a biocide to me is something used to treat either inanimate surfaces or the skin, whereas a therapeutic antimicrobial is used to treat infection, either an antibacterial, antiviral, or antifungal. And the reason for that distinction is important because there are inherent differences in biocides and therapeutic antimicrobials, where most of the time biocides have multiple cellular targets versus a much more targeted approach for a therapeutic antimicrobial. Resistance to a biocide is probably better described as tolerance or reduced susceptibility, whereas to a therapeutic antimicrobial, it can really halt the therapy altogether. Challenges around measurement of resistance as well. And in both cases, the mechanism of resistance can be intrinsic or acquired. So I think I'm not too worried about the prospect of reduced susceptibility to biocides, because it's subtle, it's difficult to measure, whereas for a therapeutic antimicrobial, it's barn door. It doesn't work anymore. There's few examples of clinically significant issues, whereas we know we're running out of these antibiotics, antivirals, etc. We've been using the same core chemical agents for decades without failures, whereas it doesn't take long when a new therapeutic antimicrobial is on the scene for resistance to develop. And finally, we can formulate our way out to a degree of reduced susceptibility to biocides, whereas that's harder in a therapeutic antimicrobial space. Curtis, where do you stand on this?
I'm in agreement. I think there have been a couple of interesting case reports where if you use a quaternary ammonium product inappropriately, and allow the organisms to mix with the quat for extended periods of time, you can get emergence of quat-resistant gram-negative organisms. But other than that, I tend to agree. I think we're not seeing, this is really not a major issue for biocides, but it is for therapeutic antibiotics.
Okay, so Curtis, over to you.
Okay, I was just going to bring up a couple of additional points that are related to the environment. And so one is new technologies. So this is an example from about 16 years ago. We were visited at the Cleveland VA by a company selling a product that they called the Fogmaster Junior, which had an EPA registered disinfectant, a quaternary ammonium disinfectant. It's a handheld fogger, and it delivers a mist of a quaternary ammonium product. And the salesperson came in and he sprayed a very fine mist in the room. The surfaces did not get wet at all. And this is completely ineffective and it's hazardous to be spraying quats into the air. But the salesperson was able to show us data that this is reducing organisms. The data was not related to the way the product was actually used, and this was purchased by some, Cleveland area schools. So this, I start with this as an example, um, because this is something that's faced by infection preventionists everywhere. I don't know if this is the case in the UK, but in the US, there are lots of companies with new products. Infection preventionists are every day they're coming to show us their technologies, and I would guess, and over the last 16 years, we've tested dozens of these technologies, and probably 10% of them are like the Fogmaster Junior in that they simply don't work at all, and a lot of them don't work as well as the companies tell us they work. So one of the things that we're interested in, and that we think people should talk more about, is how should we evaluate some of these new decontamination technologies. We need lab testing, so it has to be microbiologically plausible that the technology actually is going to work. EPA or FDA registration is helpful, but you have to be careful because it has to be shown to work in the way that it is actually being used. So you need real world testing to show that the product that it may be registered with the EPA, but it has to work in the way that the company is saying it's going to work. And then, finally, the most conservative thing that people can do is, look at the guidelines. If when new technologies are really effective, they will ultimately make it into the guidelines. But there's going to be a long delay before that happens. So this is a constant challenge for us in the U.S. thinking about new technologies and having people come and tell us that they have the latest and greatest thing that's going to solve all of our issues.
Yeah, Curtis, if I can just briefly
Yes.
interject there. I mean, those issues are tough in the US, and I get that. But when we don't even have an EPA list of approved chemical agents, it's even worse because you can come and say pretty much anything
Yeah.
around the efficacy of the core product as well as the way that it's applied. So yeah, completely hear that. And I've also seen a few Fogmaster Juniors, if you know what I mean.
Yes. And then number two, this is a case that a little cluster that we've had recently of C. diff infection cases on one of our medicine wards. And so we heard about this, and our nurses were asking, what should we do? Should we do a deep clean of the rooms on the ward? Because the environment is obviously, we think, maybe important. Should we do a case control study to look for shared exposures or screen for asymptomatic carriage? And so these are all things we could consider. And I think we typically have always said, well, let's go up and do a deep clean of the ward when we see an increase in C. diff. But one of the things that really has become a point of discussion in the U.S. is this, and this there are even companies now that are where you can send your samples to your isolates to companies where they'll do this for you. But should we use routine real-time whole genome sequencing to help guide infection prevention interventions? So this is a protocol called EDSHAT in Pittsburgh, where they do real-time sequencing of HAIs and when they do this, they've detected transmission that was missed by surveillance. And they have implemented interventions based on this, and they suggest that you can actually save costs by identifying routes of transmission. So, for example, they identified a wound care team that was carrying VRE and C. diff from patient to patient, contaminated ventilators that were associated with infections, and EEG equipment transmitting MRSA. So they really suggest that this is something that we should be considering more. And then I would just mention the alternative as well. Counter argument is this. You know, can we, first of all, whole genome sequencing is expensive, labor intensive, and time consuming. Can less costly and labor intensive typing methods be used? So for our little cluster of C. diff cases on our medicine ward 4B, we did PCR ribotyping, which is a much more simple typing method, and all of these patients were infected with different isolates. So we did not have any evidence on the ward of patient-to-patient transmission, and typing in this case was actually useful for us to tell us that, in fact, yes, these patients are likely coming in with C. diff that they've acquired somewhere else, and we don't have a real problem on the ward that we need to aggressively address. And so this, and I know certainly in the UK, you guys do lots of whole genome sequencing. You guys were doing that, I think, before we really were doing it as much in the US. And this is something that I think does deserve consideration and might help us when we're trying to identify clusters of transmission that might be related to the environment. And alternatively, to show that some of these clusters that we think are from the environment may be not the case. And then finally, final question, can we do more to incorporate sustainability into cleaning and disinfection? So this is a big topic of discussion. I'm at the ID Week meeting now, and there's a lot of discussion around this. Healthcare accounts for a lot of CO2 emissions. Plastic waste is a tremendous cause of adverse environmental effects and greenhouse gas emissions. And it's estimated that we're really harming individuals and causing a loss of life years by this, by healthcare and other carbon generating things like that. And so one question is, should we think more about sustainability in the environment and environmental cleaning and disinfection? So here's a picture on the left of ready-to-use wipes that we have in our facility. Lots of plastic containing wipes and plastic containers, and they use a lot of these chloroclean type tablets in the UK, where you drop the tablet into water and dilute it. So you're missing out on lots of plastic that we're using here in the US, and it's just something that we should be incorporating into our thinking when we're thinking about environmental cleaning and disinfection, I think, everywhere. And so, John, back to you.
Yeah, I mean, Curtis, I think we could talk all day about this. All of these issues are so fascinating, so important. I'm really happy that we're able to have this discussion today. We wouldn't have been able to have it 20 years ago because the quality and the volume of the evidence just wasn't there. So thanks for all the work you continue to do in this space, Curtis. It's appreciated this side of the Atlantic.
Thank you, and likewise, we appreciate all the work being done over in the UK as well.
Well, thank you very much, both. I was absolutely dying to join that conversation of yours. And I've got lots of questions, but because of time limits, I probably cannot ask those questions because we'll be here for another 15, 20 minutes. And I have to think about the audience. But thank you so much for a fascinating teleclass, lots of discussions, obviously lots of issues you raised. For me, the main one is when we're talking about disinfectant product, we forgot about the end users. If the product is not used properly, then obviously it's not going to work as well. And I had quite a few questions around that to ask both of you. I've got questions about resistance as well, on so on. So maybe for another day. But again, thank you very much for a fascinating teleclass. To the audience, you might have noticed a bit of background noise. in that recording is because Curtis is joining us from a conference in Atlanta, which explained the background noise. But again, thank you very much, Curtis, for your time. Which reminds me now to the end of this teleclass lecture. So I'm just looking at the forthcoming teleclass for the rest of October on November. You've got that on the screen. Please do attend. They're always fascinating to listen to. And finally, I'd like to thank our patron sponsors, Diversity, Virox, and Gamma, to make the teleclass possible. So thank you again for listening, and hopefully you'll join us for the next teleclass. Thank you, and goodbye from me.